Hello, everybody, and thank you for joining us today for this Ask WHO Live, social media live. Today we're going to be talking about a disease you probably know about, Ebola, and an outbreak you may not know about of Ebola in the Democratic Republic of the Congo. And we'll talk about why it's good that you know about it or don't know about it, and how WHO is helping the country to respond to this outbreak of Ebola. I have with me today three people, three experts in the field. So right to my left is Dr. Chikwe Ihekweazu. He's the head of WHO's Emergencies Program. He's the executive director of WHO's Health Emergencies Program. Then we have Dr. Janet Diaz. She's the head of Safe and Scalable Care, and she'll explain what that means. It's basically looking after patients with a range of different diseases, especially in emergencies. And we also have with us, joining from Bulape in the Democratic Republic of the Congo, Dr. Maury Keita, who's our incident manager there. And Maury, I'd like to start with you. At the moment, in this outbreak, there hasn't been a new case in 20 days, which is excellent news. However, 64 people have become sick with Ebola in this outbreak, and of those, 45 people died. Ebola is always a tragic disease, but there's more and more that can be done, as we've learned over the years how to manage it. So tell me, how are we and the colleagues from the Democratic Republic of the Congo managing this outbreak? What are you doing these days when there aren't new cases coming? What work do we still do while we're there?
Thank you, Nika. I know Ebola is a very serious disease and a major threat of global security. We were deeply concerned when we first heard about, some cases being reported in the DRC. Even though this is the country's 16th recorded outbreak and the third in Kasai province. At least effective treatment and vaccine are now available for Ebola. So regarding the latest situation, I think you have just mentioned it. It's worth noting that there have been no new confirmed cases for 20 consecutive days, which is a significant milestone. There is now only one confirmed case remaining in the Ebola treatment center. His health condition is stable, and we expect him to be discharged after two negative tests on Sunday, 19th of October. This will trigger the 42 days countdown before the end of the epidemic is declared. So today, the 21-day follow-up for all the 178 remaining contacts will be completed, and the contact tracing will end tomorrow. This indicator show we are moving in the right direction, but it's too soon to declare victory. We will maintain our current intensity and continue improving the quality of our intervention until the end of the outbreak is officially declared over.
Thank you. Ebola always demands of us that we stay vigilant because it's such a dangerous virus, because it can kill so many people. But one of the things that has really changed over the years, it used to be that if there's an outbreak of Ebola, 90% of the people, so 9 out of 10 people who become sick with the disease die. And over the years, that has changed, and in each outbreak as well, we seem to be able to manage it better. Dr. Keita mentioned that treatments are available, vaccines are available to protect communities. He said that that's continuing as well. But I wanted to turn to Dr. Janet Diaz, who's really a global expert in Ebola care, and ask two things, but I'll start with the first question. So how has Ebola treatment improved over the years? Why is it that we now say that the mortality rate from Ebola ranges from around 30% to 90%? Why is it that we are able to save so many more lives now?
Thanks, Nika. Well, there's been amazing work that's been done over the past decade with various ministries of health, with partners, to accelerate our optimization of the standard of care, so optimizing the standard of care, as well as the evaluation of therapeutics in that context. So, but to give you a more simple answer, one is early diagnosis. So we do know the early diagnosis, early recognition of a patient with Ebola, so very early in the disease, if they get into treatment and get the optimized supportive care and get the life-saving therapeutic, because for Ebola Zaire, we have two options, then their survival can actually be as low as 10%. And that's what we showed in one of the clinical trials back in DRC in the North Kivu. So
Survival as high as 90%.
yeah, survival as high as 90%.
Just before you go on, Janet, I just want to unpack a couple of things that she mentioned. So she mentioned standard of care, and that sounds very technical. And I'll explain what I know of it, and then help me if that's not clear. So basically, that's the care, the treatment that patients get when they go into a treatment center. It used to be, my understanding is, when there was an Ebola outbreak, you would just take people who were sick out of the community to make sure they didn't spread it, but there wasn't much you could do to help them. And now you run many tests. The health workers in the treatment centers run many tests to make sure people aren't suffering from another disease, that their blood sugars are at the right level, and so on. So just to make sure the body is as healthy as possible. And then you mentioned therapeutics, which is treatment. So there are actually specific medicines to fight Ebola now. Yeah? Okay. So then you were in Bulape yourself, I think 2 weeks ago now. What did you see there? What did you see in terms of how we are helping countries to be better ready to fight an outbreak?
Well, when I actually arrived with Maury, my colleague, in the field, and we were the second team to arrive. It was a team of colleagues from WHO, the senior colleagues from the Ministry of Health, that were leading the response, and colleagues, partners as well in the field. And what we found collectively was, the local teams had already put into place some of their early interventions, but things were still, very, very challenging. The area is very remote. We were the first group to arrive by the air bridge and the helicopter to the field. Prior to that, everyone was taking the road, which was taking many, many days to get there.
3 days to get in. Yeah.
So what we had found is a treatment center, the beginnings of a treatment center, or the isolation and treatment center that was established at the Bulape General Hospital. However, they were working under very complex conditions. The staff, there was not sufficient water access, and to care for Ebola because of the infection prevention and control measures that need to be in place. You need, stable access to large amounts of water to ensure biosecurity and safety. The second was there was not sufficient electricity. So at nighttime, there was, the medical team was working in a tent, a small little tent outside of the red zone, which was in the buildings of the treatment center, that they had to work under with flashlights on their head because we didn't have full electricity to give light both inside the treatment center as well into the medical, the tents that were the medical teams and the clinical teams were working, rounding, writing in their papers. So really limited access to medicines. There were medicines there to deliver some of the basic treatments, but still not enough, and not all the right medicines, and not all the right monitoring equipment. They had pulse oximeters, blood pressure monitoring, but didn't have biochemistry testing yet. So as you described, we've worked to improve the standard of care with testing of basic biochemistries or clinical labs, but those were not all available when we arrived. Also, access to oxygen, one of a life-saving intervention in patients who are critically ill, also was not available when we initially set foot.
So I find it interesting because the country has seen, this is the 16th outbreak, as Dr. Keita mentioned, but for each new community affected by the outbreak, for each new hospital that's facing an outbreak, it's anew, and the health workers have to learn how to manage this particular disease. We have a few questions on social media now, and so I will, yes, go ahead, Janet.
One more thing, yeah. I do also want to acknowledge what was there.
Yes.
Because what was there was the laboratory, the diagnosis. So patients were able to be diagnosed quickly once they were identified. Now, that requires good surveillance, right? Good surveillance, good community surveillance. But that was there, and I think that was a definitely value added because patients were being diagnosed and then put into the treatment pathway. The second thing that was also there when we arrived was the availability of one of the monoclonal antibodies, and this is the monoclonal antibody 114 that was actually discovered and in the DRC in one of the past remote outbreaks, and that was available also when we arrived. So there were some things of the package of care that were there, but there was obviously that's one of the life-saving treatments, the monoclonal antibody. But other things, because of the remote nature and because of the fragile health system that is in that area, that some of these other supportive care interventions were not available.
So that's what we help bring in, and I'll come to you next, Chikwe. But I just want to mention, of course, this is Social Media Live. For those of you who are watching us on X, you can do hashtag AskWHO to put your question in there. On Facebook and LinkedIn, just put your questions in the comments. Our colleagues are monitoring for them, and they send me your questions, and that's how we know what you're asking. One of the questions, I'll come to you, Maury, for this one, actually, and then I'll go to you, Chikwe. Jafar Sharif is asking, how can we survive? How can we protect ourselves from Ebola? It's one of the key interventions is working with the community to help them, those who are most at risk, those who are most likely to catch the disease because it's in their community. Our communications teams, our community teams work with them to help them understand the disease. We work with community leaders so that they can be the ones speaking to the community. So can you explain what messages what kind of questions people ask us and how we explain how you can protect yourself from Ebola?
So I think to protect ourselves from Ebola, we need an integrated approach. We have just said we now have a vaccine, we have a treatment, but before being sick, I think we need to prevent it. And vaccine is there for that. So I think we are recommending, to vaccinate, healthcare workers, all those who are at risk in the health area that are affected to be vaccinated. And but we are prioritizing the contact. So those who have been in contact with a confirmed case, contact of contact, and in a very limited area. So all these people need to be vaccinated. But one of the critical issues is also about, the IPC measure at the health center and at the community level. We need, water. Even recently, WHO, we have been able to support, the tracking of the water from around 3 kilometers to the Bulape health centers. So we need water in the health centers to avoid nosocomial infections and to also avoid community transmission. So IPC need to be applied at all levels, at the community and health center level. And we also need strong communications. Communication is key in Ebola outbreaks. People need to know exactly how to prevent it, how to take care of a confirmed cases, how to maybe to avoid or being contaminated. Issues are very important. So again, we need an integrated approach, to respond or maybe to protect people who are at risk in Ebola affected area.
Thank you. Jafar, in answer to your question, and also we have a similar one from Aminu Lawa'al, who's asking how fast the virus replicates in the body before you have symptoms. WHO has excellent materials on Ebola on our website. So just search the word Ebola on the WHO website and you'll see some fact sheets and guidance. I know that our community workers help people understand the disease better because there's this sense that as soon as you have Ebola, you'll be bleeding from everywhere and only somebody who's bleeding has Ebola. When in fact, when people are first sick with the disease, they feel like they're sick with, as you would with the flu. You're just feeling really unwell, extremely tired, a headache. So we help people in affected areas look out for those symptoms and help each other. If somebody's having those symptoms and you're in an area where there's an outbreak, you have to be very careful and present for care. Chikwe, Maury mentioned integrated response, and that's something that isn't not an individual that does that. It's a whole of community, whole of government, and government plus WHO response. So when you hear integrated response, what does that mean, and how does WHO help countries to do that?
Yeah, Nika, thanks a lot. Maybe before I answer that, I remember it must be right on 21 years ago, went for my first Ebola outbreak, a few 100 kilometers from where this one is happening. We literally went in with nothing other than, listen, look after yourself. I was playing the role Maury's playing today. And we literally also left nothing behind. We did our best, managed that outbreak, and it was heartbreaking for me as a young epidemiologist at the time, leaving Yambio. But this time, it's so fundamentally different to answer your question. Even before we arrived, a sample had been taken, sent to the central lab in Kinshasa. They had sampled it in Kinshasa. When we went with a strong team from the new National Public Health Agency, Institut National de Santé Publique in DRC. They assembled a team. We went together. So a lot of the work that we do on the field and we did in this outbreak, whether all the things we do normally, manage cases in a facility, do the contact tracing, educate the community, go out, look for contacts, follow them up. All of these were led by national level colleagues. So really what you can think about integration in many levels, but really integrating, of course, the different parts of the response, but also the different institutions. And we have worked very closely with the national institutions here, responsible, both local, regional, and national in the DRC. So for me as executive director of the emergencies program, at no point in this outbreak was I excessively anxious. Once we detected the case, I knew we had a strong team. I knew we knew what to do. And I knew that we had a strong national institution in DRC that also knew what to do. The key thing, using that word integration, is how do we all work together, play to each other's strengths, and deliver a good response. And so now, 20 days into the response, we're not out of the woods. We have to keep pushing on all aspects. But, I rest assured that we understand what we need to do. And the key thing is to keep learning, keep introducing new opportunities that science enables us through every outbreak to learn, and integrate it into how we are better equipped for the next outbreak of Ebola, which will come.
That's the sad part, but every time better able to respond as well. Janet, we have many questions coming in, and thank you for your questions. We have one from Carlene Gribble, who's asking on X, how are pregnant women and breastfeeding women managed, both for treatment and vaccination? Just to say, this outbreak actually started, the first sign we heard was a woman giving birth who had Ebola. The healthcare workers in that facility, several of them were also affected, and that's why Dr. Morikata mentioned the importance of IPC, which is infection prevention and control, to make sure the health centers don't become places of amplification of the disease, and make sure people know you can still go to the health centers and you'll be treated and well cared for. So just back to the question from Carlene, which was, how are pregnant and breastfeeding women managed, both in terms of how they're treated and vaccination?
Thank you. Carlene, it's a good question. We know, unfortunately, pregnant women and small children are at high risk for death associated with Ebola when they get infected. So I think number one is prevention, right? And that good infection prevention and control services are in place across the health system, in the health centers and in the reference hospital, and pregnant women are receiving the vaccine. The second thing is around early diagnosis. So it's the same, we just have to do it well across all the vulnerable patient populations. And that includes, especially for the pregnant women, when they start to develop the symptom, if they are on the contact list, or if they're in this risk zone, that the first symptom, the most mild symptom, that it's taken seriously, right, and gets a good investigation by their surveillance officers. And then if it triggers an alert that person gets brought into the treatment center, gets a test, and then we do the care. And all that care has to be done, really well. We always try to have an integrated team. So again, just to kind of go on the talking points of integration, we have a ministry-led response. But in the treatment center too, it's ministry-led, but it's very integrated with partners. So WHO is a strong partner there to provide technical support. We have our NGO partners such as MSF, Alima, IMC, all with a wealth of experience in managing and working in Ebola treatment centers, including the care of pregnant women. But it's important to have that specialist, that obstetrician that is available to support the care, the best care possible for pregnant women as well. They also will get treated with the monoclonal antibodies, as would a newborn. If there was a newborn that was, that one of the pregnant women who was infected gave birth to a newborn, that newborn also would get access to monoclonal antibody treatment, regardless of the result of their test, because they would be so vulnerable and so high risk. So we do have our protocols in place to ensure access.
My understanding, it used to basically be if a pregnant woman had Ebola, she essentially would die. So this is a big advance as well. And her child was very likely to die as well if she had just given birth. And so in the past 5, 10 years, that's another advancement, that we are so much more able to care for everybody and anybody who has Ebola. We have a treatment. We have a question now, and I'll go to you, Maury, for this one. Maria Wilda Tagudan Silva is asking, do we have enough vaccines to contain the outbreak and for preventive vaccination? You were talking about vaccinating the contacts of contacts, and the health workers. Do we have enough vaccines for everybody, and how many people have been vaccinated so far?
Thank you very much. For vaccination, I think it's important to note that 2,000 doses of vaccine had been pre-positioned in the country before the outbreak the declaration of this outbreak. So this enabled us, the first vaccination to begin as quick as possible. So now we have been able to vaccinate more than 31,000 people in the affected health areas. So we do have some 10,000 doses in our stock in Bulape. And of course, doses are not an issue because we are in touch with ICG, and we are expecting more doses here to make sure all the contacts and all those who are at risk are vaccinated.
Maybe, Nika, if I can just add to that point on vaccination, is just how many parts of this complex picture needs to work together all the time. You have science developing new vaccines all the time. You have industry that has to take it from a trial candidate to production. You have to store them in appropriate places at appropriate temperatures. You need the logistics to take it to the field. You need the vaccinators to actually take it to the patients. You need healthcare workers to manage the patients. So, sometimes when we talk about 2,000 doses or 30,000 doses, it's almost impossible to explain the ecosystem that works together. So, and that's what we do the best, is manage this, coordinate this, bring partners together. And no country can do this on its own. No one organization can do this on its own. And you can't do this bilaterally or just with one firm. And really that's at the heart of what WHO does, is bringing together the world to respond to a specific threat that ultimately can threaten all of us.
I think that's an important point to make, because the country has capacity. That's very clear to us, as Janet was saying, and as Maury was saying. There were vaccines already in country. There were treatment in country. There was the capacity. This country has had these outbreaks before. But at the same time, there's always gaps that WHO can help fill. And we do that at the request of the country. We don't send in teams willy-nilly. It's always at the request of the country, based on their analysis of what's missing, based on our colleagues. We have a country office in the Democratic Republic of Congo. They also work very closely with the ministry, and they would be able to tell us what the requests are and what is needed for us. So that happens that coordination between WHO and the country happens at all levels, from colleagues working together in the field, the people that Maury is working with daily, up to the level of the minister and our director general. Everyone's working together at the region as well, our regional director and our colleagues there. WHO has deployed 100 people to this response based on specific needs, what was needed, further help in analyzing the cases and understanding the course of the outbreak, understanding where it might go next. Experts like Janet, who's a world expert in clinical care, so that she can help supplement the knowledge of the colleagues who are already there as well. We have a question on X from Ken, who's asking us, and I think I'll come to you for this one, Maury. Ken is asking, how does WHO ensure accurate information reaches communities during an Ebola outbreak to prevent fear and the spread of misinformation? Maury, can you tell us a little bit more about how we work directly with communities?
Yeah, I think on this specific area, we used to work with UNICEF and other partners, because to develop key messages, for the communities who are affected, but also those who even are out of the country or maybe online. We are using, contextualized messages to make sure that, people are not confusing, or maybe are not amplifying wrong messages. So, for example, at the community level here, now have an expert, an RCC expert deployed by WHO, who is originated from Mbulape. She's like in her community. In working with the community, she speaks local language, and she use her network to make sure that all these local partners, so all these local leaders are heavily involved in our response. And we are also working with UNICEF and other local NGOs, to address all the issues. And we used to do like assessment at the community level to get their feedback, because their feedback are very important for us to adapt our messages, to adapt our strategies, and to adapt even our interventions. So this is what we are doing on the field jointly with different partners, of course, under the leadership of the Ministry of Health.
And that's really important as well. WHO doesn't send people from far away to do that work that needs to be done by and with the communities. There's a lot of work that's done directly with community leaders, because we know they're the best voices. Those are the people that the community trust, and they will come to us as well with their requests. So we're always very conscious that communications is a two-way street. It's not coming in and giving people messages. It's coming in, understanding what they understand, what they have questions about, how we can provide them information, and who are the best people to convey that information. There's a question here on the vaccine, and speaking of mis and disinformation, or curiosity and uncertainty. Evangel Peter Kautzi is asking, is it possible that some people still fear or feel uncertain about the Ebola vaccine? How safe is the vaccine? What kinds of reactions or side effects have been observed after vaccination? Should I go to you, Janet, or is this more for Maury? Maury, over to you again.
Yeah. So maybe just to specify that, here in Mbulape and the surrounding area, we are having huge demand. So community are asking, because they are, I think they are aware of the disease, because as I just said, it's not the first time, for them to heard about, Ebola in their province. This is the third outbreak in the Kasai province. So they are aware of the situation. They are so fair. So they are now asking for vaccine. So of course, we can't vaccine everyone. That's why we are using a very evidence-based strategy to vaccinate those who are at risk, and those who are in need. So this is what we are doing. But of course, we used to follow them. When the people are vaccinated, we used to follow them if there is any adverse event and so on. So we have also a very well established mechanism to collect all the information about adverse event, to take care of them, and to respond to any emergencies and so on. So in Mbulape, in the surrounding area here, we are honestly on top of this issue regarding vaccination.
This one from LinkedIn, Anne Ulhak is asking, how can we differentiate the symptoms of Ebola virus disease because its symptoms are not very specific? That's actually a really good question. As we were saying earlier, there's sometimes people have this impression that the disease starts with those very dramatic symptoms that we've heard about, that you think about when you hear the words Ebola, but actually doesn't start that way, and it's really important that people are aware. So, Janet, to you, how can we differentiate the symptoms of Ebola virus disease because its symptoms are not very specific?
Well, it's very complicated. It can be very complicated, I would have to say, but it's a very good question. But to be honest, at the onset, the earliest symptoms are fatigue, are profound weakness, are fever. And I think you can see that with other viral infections, but those are kind of the earliest symptoms we see, followed by then the diarrheal symptoms, the big, loss of diarrhea, and then vomiting, and the GI, the gastrointestinal symptoms, and then followed by later the bleeding symptoms. So the bleeding, like you said before, is actually a very late finding, and it's actually, can be almost like at the end, towards the terminal phase of Ebola virus disease. So what we would like to do is get to a point where we can diagnose really early, like I said before, because that's when the opportunities for best outcome are there. And then the things that you don't see for those clinicians out there, you just develop different organs get affected. Your kidneys don't work so well. Your liver doesn't work so well. You get something called rhabdomyolysis, where your muscles are also not working. That's why you have so much profound weakness and fatigue. And so there's a lot of things going on, and as the days go by with the disease without treatment, these things can get worse and worse and worse. So I think you have to be, for those clinicians out there, sometimes you see a lot of malaria, right, or severe malaria. But if the patient isn't really acting like malaria, responding quickly to your antimalarial, start to think of other things on your differential diagnosis. Remember where you are, where you're working. Has it been an endemic, or an area that has seen Ebola before? So always keep it on your differential diagnosis, or the possibilities. It may not be the number one, but maybe it's somewhere on there. But it always takes one astute clinician and an astute public health officer together thinking of the disease. Because if you don't think, then you won't test. But if you think about it, then you say, okay, it possibly could be this. Let's test. And during an outbreak, obviously, then that your heightened surveillance, your heightened consideration of even the earliest symptom, if you're a contact, we would take seriously.
And that's why that community work is so important, because the people who are most at risk are the people in the communities where the disease is spreading. Of course, other areas need to be vigilant as well, and WHO does a risk analysis precisely to say that, where should people be most worried? So within the country, yes, because people within the country can travel. Perhaps the immediate neighboring country or anybody neighboring that zone should be vigilant as well. If you're further away, no, the risk is very low. But that's the importance of making sure the people who are most at risk are most aware, and not just the community members themselves, but as Janet was highlighting as well, the health workers in that community, that they are aware and are keeping vigilant for those early symptoms. I often think it's been a real disservice to Ebola response that there is this exaggeration or a real focus on those end symptoms, which doesn't help in a community that's affected in the early stages. You need to look out for what Janet was mentioning, those early signs. The next question is on LinkedIn. It is from Jacob Kashililika, who asks, how is the WHO strengthening integrated disease surveillance and community-based alert systems in border communities? So that's what we were just talking about, that rely heavily on informal transport to ensure the earliest possible detection of the potential EBD case. So this is something that WHO does because it can coordinate with neighboring countries. It can coordinate with other countries who become very curious and want more information when they hear that there's an Ebola outbreak. So how does WHO do that work with border communities and anyone else that might be at risk?
Yeah, Nika, maybe I can take that, because I think we're still all traumatized by the events in West Africa in 2014-15. And that's exactly what happened. The first cases evolved in this small community, Keruku, in the south of Guinea, in between, near the borders of Sierra Leone and Liberia. And kind of, our borders in the African continent are what they are. They're not what you imagine full borders to be. So we have to make an extra effort, firstly, to find the cases, and secondly, to report them. And that's why the whole IHR, International Health Regulations mechanism exists, so that we support each other. Every country, every member state is empowered and able to share information, even without full verification of what it is. You may not even be, but once you know what the pathogen is, or the bug causing the illness, but once you see an unusual number of cases, or people passing away, or maybe a healthcare worker affected, anything that would trigger an alert, we now have a very robust information sharing. Not all of it is public, because it's shared among the people responsible for doing this work in each of these countries. WHO coordinates this, but it's kind of a safe environment for countries to share information with each other, so that then they can trigger a response and ask for our support where it's needed.
And if you're curious about that, actually, what Dr. Chico was just mentioning, that we give updates to countries so that they can follow this, very often, much of that same information ends up in disease outbreak news. It's a product we have on the WHO website. You can subscribe to them. There's regular updates on Ebola, on other types of outbreaks. So it's a good way to keep track of what WHO is working on. And it's really quite a detailed document. So that gives you a sense of what kind of information WHO is sharing with other countries as well, because donors, they are curious. They are following closely what's happening in their neighboring country. And as Chikwe said, because of how broad the 2014-15 Ebola outbreak was, how many countries were affected, there were some travelers as well. Because of that, there is extra attention for Ebola when there's an Ebola outbreak. So back to what I was saying, subscribe to Disease Outbreak News if you want those kinds of updates. Another thing that WHO does is we can bring in money really quickly. And as Janet highlighted, as Maury mentioned, it's so important to move quickly when an Ebola outbreak starts. And what enables WHO to move quickly and to support the countries quickly is a mechanism we have called the Contingency Fund for Emergencies. That's money that's sitting there that we can immediately use for a response. So Chikwe, can you do a plug for the CFE and explain why it's not really so much for individual donors, but why we think it's important for your countries to contribute to that?
This is a big lesson we learned out of that West African Ebola outbreak, that, what we do in the first 24, 48 hours of any response really is the heart. That's what determines, will this be a small cluster, a large cluster, a big epidemic, or a pandemic? So it's important for us to get out of the door quickly and enable our countries get out of the door quickly. So we've established this fund that enables us to move very quickly. It's supported, of course, by member states around the world, by organizations, and we need to keep replenishing this in order to able to continue doing this. So yes, we're working very hard on a pandemic agreement at the moment, our member states are, but ultimately at the heart of our work, the work we do every day of every week of every month of the year, is to detect small clusters and manage it as quickly as possible. And the more we are resourced to do this, the better. So we really need us to come together, not out of charity, but out of solidarity. And that's a principle of the work we do here.
Not out of charity and not out of self-interest, really. It's for the best of everyone in the end. So am I right, just to make sure I got my figures right, in the immediate few days we released $500,000 and so far $20 million towards this response. So we just have a few short minutes left, and I want to wrap up with something we've talked about a little bit already, but what we're leaving behind, the legacy of this outbreak and how the community, those health workers, will be better ready. So I'll start with you, Janet, on the treatment center side. We've been showing video here as you've been watching of some of the equipment that's come in, of some of the treatment centers that have been set up. But can you just speak about that a little bit, what we're leaving behind? The water you mentioned already and electricity, which will be really important for the community themselves.
Thanks, Nika. I think it's super important to say that this is the first outbreak where we've been able to deploy an innovative treatment center, rapidly deployable treatment center design. And I think that's important because it reflects about 5 years of work. It's called, the program is called Initiate. It is a program that's been sponsored by WHO and WFP partners, as well as many academic institutions and other partners. And we've been working on innovations to improve clinical care, to improve health logistics during outbreaks. So what was deployed this time to the field in Bulape, it took us a little bit of time just because of the logistics were hard to get our tents in place, but what you can see is a infectious disease treatment module, which is actually an inflatable treatment module that has 2 ICU type of beds, a nursing station, so you can take care of critically ill patients within that treatment module that can be put up in hours. We also deployed within, kind of these high performance tents, which are 24 meter square tents, meter cube tents, these patient liners, which also allow these transparent patient liners. And I guess just to visualize it, it means no longer are you inside one building where when you go into the red zone to take care of the patient, you have to go in full PPE, and you go inside and you can't see anything that's happening on the green side, in the green zone, in the patient, where the staff is. In these new design modules, because of this transparent screen, people that are working in the green zone can actually see the patient that's in the red zone, or your colleagues that are inside the red zone that are caring for the patients directly in their full PPE. and you can interact together. You can actually monitor the patients better. The families also can, under monitoring, also see their family members that are inside the red zone. So this innovation, I think, has been it's a game changer. It's the first time we've deployed during an active outbreak, and that's a legacy that we will leave behind in DRC and work with the national government on how these, because you can, after it's done, the outbreak, we can decontaminate it, get it all ready, pack it up, and that could be used and deployed for another, for the next outbreak. So, and we'll work with the local teams to ensure they're fully ready to do that.
I'll come to you last, Chikwe, so be ready for it. But I'm going to go to you, Maury. Can you also tell us, and since you're right there in Bulape, can you tell us what else WHO is leaving behind for people? Leaving behind doesn't sound good, but what we have built and what we are, what people will still be able to use next time, aside from the treatment center.
Thank you, Nika. I think one of the big achievements for us, is this 3-kilometer water pipeline. So it's the first time for Bulape community to have water, drinkable water, and so on. So this will be used by the health facility, which will also contribute to prevent infection, at the health centers, but also it will allow community to get, drinkable water, and to also use them to avoid, contamination at the community level. This is one of the key achievements. In addition to that, we also intend to renovate Bulape health centers and other maybe 3 health centers in Bulape health zone, because if you take the epidemiology, you will see most of the cases were coming from 3 main health areas. So we intend to renovate 3 health centers in these main affected areas. So these are just among others, some of the key achievement we wanted to leave behind here. So Bulape will be not the same before this outbreak.
Thank you. Thank you for your work as well. We're always so proud of our colleagues in the field. Thank you, Maury. And then lastly, Chikwe, before we wrap up, we've talked about concrete things we're leaving behind. Do you have a view? Is there something not concrete that we're leaving behind? Is there something in terms of cooperation, something that you said you were very reassured during this outbreak that all the steps were being taken? Perhaps it's building on things that we've left behind previously, networks and approaches that we've developed previously. So if you could sort of riff on that.
Yeah, Nika, I think the most important thing we're going to leave behind in Bulape and in DRC is something I experienced myself. Is when you have an international team like ours with all our partners coming to a small town, it's impossible to describe the inspiration they derive from it, the excitement about science, it builds and pushes and thrives and drives so many instincts that will ultimately lead them to seek more for themselves. And that's really the most important thing. I mean, the innovation is great, the new treatment center, the vaccines, the therapeutics, all the other tools that we've never had, the water, the electricity, the community will be transformed as much as we can. But ultimately, we will never do for Bulape beyond what they will do for themselves. And the people that will do this are the young people, the colleagues that have now worked with us for 6 weeks and will continue till the end of the outbreak and will be inspired and pushed to do more for themselves.
Thank you. So as we said earlier, there have been 20 days now, almost 3 weeks without a new case. There's 1 person in the treatment center still. And Dr. Keita mentioned he seems to be doing quite well. He's stable. If all things go well, he will be out of treatment by Sunday. And then the countdown starts to the end of the outbreak. It's two cycles of 21 days, so 42 days from the time that the last patient is released from care. I wanted to thank you for joining us today, and I'll say where you've joined from. Colleagues, people have joined from the Democratic Republic of Congo, and this probably matters especially to you. Nigeria, Laos, Argentina, Ghana, Turkey, Tanzania, Egypt, Lesotho, Qatar, Malawi, Canada. Shout out to Canada, Iran, Pakistan, Algeria, Bolivia, Bangladesh, and Cameroon. So thank you very much for joining. Tune in for our next lives. We have these regularly. Let us know what you're interested in hearing about, any topic you'd like to hear. We did one on mental health earlier this week. Thank you again. Thank you for your participation. Thank you for your questions. And thank you, Maury, Janet, and Chikwe for joining today.